and all participants are currently in listen-only mode. Please go ahead and place your phones on mute and eliminate background noise. It looks like most people are listening in through the computer, so that shouldn't be an issue. When you would like to speak, please unmute your line and follow the on-screen prompts. If you're using your computer speakers, please mute those as well if you're not speaking. You can find the call-in number for the webinar on the right-hand side of your screen. Also, throughout the webinar, questions may be submitted through the webinar by typing your questions into the dialog box on the right of your screen and sending it to the organizer. We'll answer as many of your questions as time allows after our speakers have presented, and there may be some time also within to ask the questions themselves. If at any point during the webinar you experience difficulties, please call Citrix Tech Support at 888-259-8414. Now I'd like to hand it over to Jeff Capobianco, where he can provide a brief overview of today's webinar and introduce our presenter, Eric Vanderlip.
Thank you, Carlos. Welcome, everyone. It's great to be back with you, our friends in Montana, and it's really great to have Dr. Vanderlip here. He is the George Kaiser Family Foundation Chair of Psychiatry and Assistant Professor in the Department of Psychiatry and Medical Informatics at the University of Oklahoma. Both board certified in family medicine and psychiatry. He's got a pretty extensive background in integration, having done a fellowship at the University of Washington Ames Center. We're very happy to have him here, and I took a look at his slides, and I think you guys are going to really get a lot out of this presentation. As Carlos said, if you've got questions, just type them in the chat box or raise your hand. We'll take questions as we go, because I'm hoping we have a lot of questions and we don't have a lot of time at the end maybe to get to all of them. So we'll take questions as we go through the webinar, and then if there's any questions left over at the end, we'll take those at the end. So please feel free to type those questions in. And welcome, Eric. Thanks for being with us. I'll let you take it away.
Thank you so much, Jeff, and thanks, Carlos, and thanks to the National Council for helping to set this up. And it is a privilege to be talking to you all up in Montana. I have a sister-in-law who lives in Missoula, and I have a special kinship and place in my heart for Montanans, I guess, as a result. So we have a number of objectives for today, and I hope to make this about as clear as mud for everybody, because this whole world of integrated care is complex. Job titles, roles, and the notion of what it is to become a primary care provider or a psychiatrist or a care manager or a nurse or a psychologist, they're all changing. And they're going to require us to think differently about how we view ourselves in healthcare and how we view ourselves working together. Whose job is what? And so we've got some objectives. Specifically, we'll be looking through the lens of a particular model of integrated care called collaborative care as a way to highlight how these roles are shifting. But collaborative care is just one approach to integrating behavioral health services in primary care. It's the one I know best, and it's the one I hope to impart to you today as a framework through which we could consider how a primary care physician and a psychiatrist's roles are shifting. We're going to talk about some of those essential elements behind the collaborative care model. We're going to talk about the specific roles then and the skill sets of that primary care physician and the psychiatrist in regards to that collaborative care model. And then at the end, I'll point you to some resources, and I'm hoping also Jeff might be able to chime in a little bit on some resources that are available through the National Council so that we don't just leave you hanging with this stuff, so that you've got some place to turn to if you all aren't familiar with some of those resources already. So next slide. Am I controlling the slide deck, or Carlos? Oh, there we go. Oh, don't have any particular disclosures. I usually read this because I like reading it. I don't have any pharmaceutical industry ties, Swiss bank accounts. I won't be discussing the use of any off-label treatments, therapies, medical devices, or scooters. I won't be discussing drugs to make people feel better. I'll be discussing people making people feel better. I don't own any people. My wife owns me. Next slide. These are my bosses, my children. I've got 4 of them. There's a lot. Next slide. When you look back on your life, it's hard to know how you're going to get where you are now, or to predict where you're going to be in the future from where you are now. But looking back, it seems obvious. That's why I have this picture of this winding road. It seems like this winding road, and you can't really know where you're going to start out. So, so I'd like to describe a bit about who I am and where I came from. Next slide. Back in medical school, I had a mentor. He's on the right there. That's a picture of Barry Switzer. He wasn't my mentor. Jerry Clancy was my mentor. He's a community psychiatrist who is from Iowa City and imparted to me in medical school some of the basic problems we have in our society, namely that folks with mental illnesses die at early ages because of advanced medical problems, namely cardiovascular disease first and foremost. They die from cardiovascular ailments 25 years earlier than general U.S. populations without, say, serious mental illness. I learned about this in medical school, and next slide, and then sought training at the University of Iowa Hospitals and Clinics. This is not exactly what it looked like, but not far out of the University of Iowa were a bunch of cornfields. There I did a family medicine and psychiatry program where I was board certified. I became board certified in both primary care and psychiatry so that I could deliver care to people with mental illnesses and help to overcome the disparities in their access to good cardiovascular care, preventive primary care. And after 5 years of literally co-locating my brain, next slide. After 5 years of literally co-locating my brain and kind of teaching myself all about behavioral health and all about primary care, I discovered that it wasn't my knowledge that was the rate-limiting step to getting somebody better. I'd see somebody with schizophrenia in my primary care clinic, and I'd have a really hard time having a full, informed discussion around their colonoscopy, or whether or not we should screen for prostate cancer, or whether or not we should start them on a statin medication. I had a tough time even getting them back in to get a lipid panel drawn, to even know if they would be eligible for a statin medication. Because it wasn't my medical knowledge. I knew that all those things needed to be happening. It was the way we organized our care system. It was the way we designed the care that we do and how we work together as a team that was the rate-limiting step to people getting better. Next slide. Back in 2011, yes, just 2011, when I was graduating from residency training, this was my conceptualization of integrated care, and it was a total mess, and it still is. And but I'm a little further down the road now, and nowadays I've benefited from further training on this. And when I looked around the country, I sought out the skill set and expertise of a group that had been trying to integrate care for a long time. Next slide. It was this guy in particular who was very helpful to me. I did a fellowship under the guidance of this gentleman, Dr. Wayne Caton, professor of psychiatry at the University of Washington. Wayne Caton is a psychiatrist who spent the majority of his professional life, mainly about the past 30 years, dissecting how we deliver care, specifically mental health care, into primary care settings. And through his extensive scientific work over and over again, trying to refine and perfect the workflows in bringing behavioral health services to primary care, we came up with what we now know as the collaborative care model. This is from the University of Washington Ames Center, which is now the Advancing Integrated Mental Health Solutions Together Center up at the University of Washington. They're the main, or one of the main, technical assistance players in terms of integrating behavioral health care services into primary care settings. And much of that was driven out of Dr. Caton's work. He was my mentor for 2 years. And this is sadly in memoriam, as he passed on about 1.5 years ago now. Next slide. And so in the U.S., next thing for it. Thanks. In the U.S., we have some struggles in part. And after I left my time in Seattle, when I left Seattle, I came back down to Oklahoma seeking to refine our health services delivery and integrated care, but also to use big data and health information exchanges to help guide our outreach and engagement efforts. That's what I'm doing in Oklahoma now, and I show this slide because Oklahoma is one of the places that has some of the worst health disparities in the country and the worst outcomes as a population. But I feel like when I'm giving this talk, I'm usually talking to an audience that knows what I'm talking about. Those who live in FQHCs and in primary care practices anywhere in the country can understand what a challenge it is to deliver care and services to very challenging to engage populations. Just today we were reviewing some surveys and feedback we've had from a care management program that I help oversee here in Oklahoma. And we've got about a 15% response rate on the surveys we've been doing because we cannot find people after we've tried to engage them in care management services. Their cell phones don't work anymore. We get error messages when we're calling them. And that's 80% of the people that we're following up with. Their phones just simply don't work anymore. And so we're having a lot of turnover and a lot of challenges in engaging and outreaching to these populations that need the most help. So that's kind of who I am. Let's move on to the next slide. I work in a clinic now that's run by, named after this gentleman, Wayman Tisdale. It's in a very underserved part of town in Tulsa. Next slide. This is a map of Tulsa, Oklahoma. Tulsa is a very segregated community in a lot of ways, and the clinic that I work in, actually delivering psychiatric care in a co-located clinic as a psychiatrist in a primary care clinic, is all Medicaid, underserved minority populations, and it's a very challenging environment to deliver services in. Next slide. So when I look back at things, who am I? I'm an architect for healthcare services, specifically around integrated care. But at my heart, I'm really just a community psychiatrist. Next slide. And next slide after that. So that brings me back to the original point of this talk, which is integrating psychiatric care, behavioral health services into primary care, and the shifting roles of providers. So I have two main objectives here. Next slide. The first objective, next thing, there you go, is the chronic care model. And we've really got to get into this because chronic illnesses are what's killing our population. And we're going to go through this. We've got to dissect this model and some of the more recent iterations of it. Next slide. The second objective is we're going to talk about horses and buggies. Not really. We're going to talk about how things have to change. We're going to use a metaphor to get this point home. So moving on. Next slide. So when we talk about integrated care, as I mentioned already, integrated care is a big umbrella term that encompasses basically everything that could bring behavioral health services to primary care services or vice versa, primary care services and prevention and wellness services into behavioral health settings. So there's this catch-all term called integrated care, and behavioral health services being both mental health care and substance use disorder care, substance abuse services. Both of those being behavioral health. But then another third thing, a third arm to behavioral health, is health behavior change and the psychology of healthcare, engaging populations in their care and motivating them to choose better, choose healthier lifestyles. Next slide. So with regards to this being an umbrella term and integrated care being an umbrella term, there's a narrower subset that focuses on the fact that many mental illnesses and many health behaviors are chronic illnesses. And what we need to manage chronic illnesses is a chronic care model. And so we've got to dissect this a little bit. Next slide. So why talk about the chronic care model? Next slide. Because our population simply is living and dying and managing with chronic illnesses nowadays. If you look at this, this is from the JAMA U.S. Burden of Disease study, and I don't expect you to necessarily read all this, but this is from 2010. This is data from just before 2010. And all the red stuff is infectious disease. The green stuff is accidental injury, trauma, road injury, etc. And then you've got all this stuff in the middle, which is non-communicable illness, of which a significant portion is mental and behavioral disorders, neurological disorders, diabetes, etc. This graph represents across the lifespan what is killing Americans and disabling them. Next slide. This is another way of showing the same thing between 1990 on the left and 2010 on the right. You can literally see here how in just the scope of 20 years, things like road injury, which was number 4 in 1990 as a leading cause of disease, injury, death, sinks down to number 9. And the things that start to replace it are things like major depressive disorder, number 5, other musculoskeletal injuries like low back pain, which is actually number 3, but then other musculoskeletal aches and pains, stroke, diabetes, chronic obstructive pulmonary disease, ischemic heart disease. These are all now non-communicable illnesses and chronic illnesses that have to be managed over time. Next slide. Globally, we see the same pattern in developing countries. This is from the Lancet in 2007, showing that of all the things taking a toll on disability in the whole, across all populations in the world, we see unipolar major depressive disorder as the major thing limiting populations in their economy and in their disability. Next slide. And a lot of you have seen this. This has been published in a lot of different places. The fact that most of our health outcomes in society today are determined by behavioral problems, behavior change, poor dietary habits, poor exercise, and then the way in which we deliver healthcare services. The actual delivery of healthcare services is a very small portion of health outcomes. Next slide. There is this book published in, I can't remember, a decade at least ago, called The Biography of Cancer, the Emperor of All Maladies, positing that the number, for our healthcare system, if we can cure cancer, if we can get on top of cancer, we've beaten everything in medicine, in modern medicine. And I actually think that the Emperor of all maladies today is diabetes, because diabetes is something that is the quintessential chronic illness. Next slide. And that brings me back to point number 1. In the 1990s, a group of physicians and healthcare experts who ran a large health maintenance organization or health management organization, Group Health Cooperative in Puget Sound, were looking around the world trying to figure out how they could better deliver care for people with diabetes, the quintessential chronic disease. And they came up with the chronic care model. The chronic care model was originally meant to be primarily driving reform around diabetes, because even in the 1990s, diabetes was a scourge upon primary care. If you look at this model, it's really interesting in how it's been adapted over the years. But it's a seminal piece of work from the mid-1990s that guides us today in our best evidence-based integrated care implementations. If we start down at the bottom, any healthcare system change aims to improve outcomes through productive interactions between a prepared, proactive practice team and an informed, activated patient. And I know that a lot of you have already been through this before and gone through this model, but it's really important to dissect it again with a fresh set of eyes. So I want to take a second to do that. So productive interactions between a prepared, proactive practice team and an informed, activated patient. You get a prepared, proactive practice team on the right through reorganizing how we design our health systems and the organization of healthcare. We've got to have informatics and information systems that tell us which populations are sick. We've got to have decision support, aka algorithms of evidence-based care that we can plot people out on and know when their hemoglobin A1C, for instance, is 8.5. We know exactly what we need to do next. That's a clinical decision support based on evidence-based algorithms and care. And then we need to organize how we work together and design and deliver our systems and our healthcare systems to focus on these outcomes through these improved interactions. Then we need to, on the left side, develop informed, activated patients that can manage their illnesses on their own. This is recovery in the mental health world, but it's also self-management support, health literacy, a bunch of other things that we talk about in today's common vernacular of healthcare reform. All develops this informed, activated patient, somebody who's engaged and motivated to care for themselves. And in order to get there, you've got to have community resources and policies. You've got to have sidewalks and a way to exercise and gym memberships and calorie counts on McDonald's menus, and all this stuff gets into health policy and other things. This is part of this chronic care model. Next slide. So, and you can advance this slide, but stay on it. Thank you. So researchers at the University of Washington were looking around themselves, Dr. Caton in particular was looking around himself and struggling to blend behavioral health services into primary care. Since the late 70s, he had been a psychiatrist working in a primary care clinic. And they discovered through several different failed randomized controlled trials that they weren't successful in delivering on its consistently improved outcomes for depression, especially in primary care settings. And with that frustration, they looked around and borrowed from this chronic care model with Wagner et al. And repeated it for depression. They simply borrowed from diabetes care and this chronic care model and said, depression's a chronic illness. Why don't we take that model and riff off of it for a while? And in 1995, they came up and coined the term collaborative care. And then in 2001, they had one of the first randomized controlled trials called the IMPACT trial, which is the first kind of bells and whistles version of collaborative care as we know it today. And then in 2010, and that was focused on depression in primary care settings, the IMPACT trial was. And then in 2010, they added back in another chronic illness for their chronic care management system, diabetes. And they called it team care when they combined both diabetes and depression together. We're going to review some of this literature and this data for a second. Next slide. This is a screenshot from JAMA in April of 1995, just showing you what was going on in their head back in 1995. Collaborative management to achieve treatment guidelines focused on having a care manager help with depression in primary care settings for the management in primary care of depression. This was one of the first attempts to do integrated care in a systematic randomized controlled trial. Next slide. This is a screenshot from Wikipedia showing what the top singles were from 1995. By the way, this is how long ago they were thinking about these things. This is over 20 years ago. They were listening to Waterfalls, Gangsta's Paradise. They might have been listening to that. I don't know if Dr. Caton was listening to all those things. But my point is, they have been thinking and working on this stuff for years. And it's taken them decades to perfect some of these models we'll be reviewing over the next few minutes. Next slide. When you dissect apart the critical aspects of collaborative care, you come up with these 4 essential elements. And this is one of our objectives for today, is to review the essential elements of collaborative care. I want to go over some of these, and I want to dissect apart this model because this model is helping us know or it's teaching us how psychiatrists' roles and how primary care physicians' roles are evolving in new integrated care models. So some of the essential elements, these are the 4 main essential elements of the collaborative care model. Number 1, that you have patient-centered care teams. And when you think about it, this is the chronic care model reiterated and advanced a little bit. So we've got patient-centered care teams, not just one person, but an interdisciplinary collaboration of people with skill sets that can help impact upon a population of people that they're caring for. So they do individual care, but they do it at this level of a population. It's very challenging to wrap our hands around, but in collaborative care, they've kind of cracked that nut. They've said, here's a population that we attribute to one care manager that's 40, 60 people at a time. That's our kind of micro population that we can manage, but we focus on that population as a whole to ensure that nobody slips between the cracks. Thirdly, they use measurement-based treat to target. So they track clinical outcomes in these collaborative care programs, and they treat until those outcomes are better, and they don't give up treatment or intensifying their treatment or engagement until that outcome is achieved. And then finally, they use evidence-based treatment algorithms to get those measurement-based outcomes better. All four of these things work seamlessly together in collaborative care. They're all four absolutely essential in order for collaborative care to take off. Next slide. If I lift up the hood of collaborative care and I was to show you what the alternator is and what the engine block was and what the transmission was, this is what I'd be showing you. So this is a diagram of the engine of collaborative care. And at the middle of this is really, well, on the left is the patient, but they're kind of in the middle of this whole collaborative care thing. And the most important relationship in a collaborative care model, the two most important relationships are the PCP and the patient, and the behavioral health practitioner or the care manager and the patient. Those two relationships are integral. So let me give you an example of I'll walk you through what a collaborative care model looks like in clinic. So let's say we're doing the impact trial of collaborative care, and that was for geriatric depression. So a patient who's 67, let's say his name is Joe, walks into clinic and screens positively in his primary care clinician's office on a PHQ-9, which is a common screening measure for depression in primary care. His PHQ-9 score, let's say, is 18 at the beginning, and Joe's PCP, Dr. Sullivan, says, "Oh, Joe, it looks like your depressive symptoms are pretty high right now. You may have major depressive disorder. Let me introduce you to Barry, who is our care manager who's running our Impact Collaborative Trial for depression, or running our Impact Collaborative Care or Depression Care Management Program in primary care." Joe meets with Barry, and Barry goes over a battery of tests with Joe, kind of screening him for substance use disorders, for bipolar disorder, and also talks to Joe to kind of understand the flavor of what's going on in Joe's life. Is he alone? Does he live by himself? Is he working? What's his income like? Is he actually taking his meds? What meds is he taking? Barry spends 30, 45 minutes in this initial intake appointment with Joe, kind of just getting to know him. And the PCP, Dr. Sullivan, and Barry work closely together. Dr. Sullivan does a warm handoff with Barry in the primary care clinic. And then let's say that happens Thursday afternoon. Barry adds Joe to his list, his registry. And Barry keeps this list active and updated. And Barry puts in Joe's PHQ-9 score of 18. And on Thursday afternoon kind of wraps up this whole initial appointment. And then the following Monday morning, Barry meets with me, Dr. Vanderlip, by phone over the interwebs, and has a discussion about all of Barry's patients. But we organize that discussion based off of, first, new patients to Barry's caseload, and then secondly, who's not doing better. And so I look over the list. We both have an internet that allows us to access that list together. And I say, "Oh, it looks like you got a new guy named Joe." And Barry says, "Yeah, let me tell you about Joe. Joe's a widowed 67-year-old Caucasian male who has been seeing Dr. Sullivan for a number of years. 6 months ago, he was started on sertraline, 25 milligrams for depression, but they never really followed up with that, and he stopped taking it after 3 months. And I, as the consulting psychiatrist, say, well, this is kind of a no-brainer. It looks like he's still depressed. I don't see any major problems with continuing with the Zoloft or the sertraline and increasing it to 50 milligrams if you say he was tolerating it before. And then maybe after 3 or 4 weeks, if he has no change in his PHQ-9, bumping it up again to 100 milligrams, especially if he's side effect free." And I, along with Barry, send that recommendation off to the PCP. Through a secure messaging platform in our EMR, for instance. And Dr. Sullivan sees it and says, "Oh, yeah, of course. Well, yeah, we wanted to do that. I guess I'd never followed up or had a chance to follow up with Joe about his antidepressants. So sure, let's do 50 milligrams of sertraline." And Dr. Sullivan prescribes it. Dr. Sullivan looks over Joe's chart briefly and thinks about the risks and benefits of that, and thinks about other drug interactions, and takes upon themselves the duty of prescribing that with this deluxe team around behavioral health supporting Dr. Sullivan to do that. And then Barry, the care manager, follows up with Joe the following week to make sure that he's filled the new prescription and he understands and gives him some basic psychoeducation about depression and side effects to sertraline, etc., in collaboration with Dr. Sullivan and with my support, the consulting psychiatrist. And then in another 3 weeks, Barry, the behavioral health practitioner, follows up with Joe, gets another PHQ-9, maybe over the phone. And let's say that it's 12 now. So we've had some improvement. The following Monday in our typical caseload review, I sit down with Barry and I say, oh, it looks like we're doing better, but we're still at 50 milligrams of sertraline. Time to go up to 100 milligrams of sertraline, especially if he's not having side effects. This is the way that collaborative care works. Next line down. Or next, there we go. And they did, the IMPACT trial enlisted over around 1,000 patients and randomized them at 8 different practice sites. And it over doubled the effectiveness of depression care in primary care. And this is just a screenshot from some of the data. This is the percent of people with improvement or response to depression treatment in primary care. It's not all just antidepressants. That psychiatrist can help that behavioral health practitioner to deliver problem-solving therapy, behavioral activation, and also deliver good motivational interviewing. All of these are evidence-based behavioral health skill sets that you can deliver in the primary care environment in short little snippets of care. This was published in 2001, 2002 in the Journal of the American Medical Association. Next line, or next slide. Collaborative care also saved money. But the interesting thing is that it saved a ton of money, not in behavioral health services, on inpatient medical care. And this is where they got a nearly $6 to $1, $6 return on investment for every $1 they invested in the collaborative care program. Next line down. Or next, sorry, next slide. So they took collaborative care from 1995, they brushed it up and called it the IMPACT model. That's what I've just walked you through. And then they added to that diabetes again. So instead of just a psychiatrist reviewing depression care, next slide, they added in diabetes, hypertension, and blood pressure, or diabetes, blood pressure, and cholesterol into the mix. They tracked all of those things in this registry and on a spreadsheet, and they used a PCP consultant working with a team, a psychiatrist consultant, and that care manager, care coordinator, to give evidence-based recommendations to a PCP who could then advance that person's care. We'll talk a little bit later in this, in a few more minutes, about clinical inertia and the need to have another system helping to move our primary care system forward in terms of providing evidence-based care, keep the ball rolling, and doing treat-to-target outcome measurement across these domains. But this is kind of a screenshot of the current registry that they use up at the University of Washington to track populations in their care. And you can see over at the right, they haven't yet populated hemoglobin A1Cs, but next slide, I'll show you a screenshot of some of the registries they used. Next slide. This is an actual registry they used in the teen care randomized controlled trial that they published in the New England Journal of Medicine. And here you can see you've got your initial baseline blood pressure, for instance, in that column, and then the most recent blood pressure. And you can scan through that quickly and see who's better and who's not. Next slide. This is an even simpler version of a registry showing patients on the left, Mary, Todd, John, Gregor, and you can quickly have your eyes go to, using this table, who's better and who's not. So I know immediately for this micro population of patients that Lucy's PHQ is better, her depression score is better from 18 to 13, but we're still not there yet. Look at John, he's doing really well. He's gone from 13 to 6 on his PHQ-9. And his A1C has dropped from 10.7 to 8.2. John's doing pretty well here, and I'm not really that concerned about him other than making sure that we have a good evidence-based treatment for his hemoglobin A1C. This use of a registry accomplishes two main things in collaborative care. It allows us to manage a population and also do measurement-based treat to target, so that we can keep our eye on the prize with what's really going to affect outcomes for these people. By the way, this is also a really neat way to integrate care, because by doing this, we've combined now primary care and general medical care with behavioral health care at the same time. When you do these caseload reviews and you have a consulting psychiatrist and a consulting primary care doc, they're both weighing in on somebody's treatment plan in real time. That's super duper high level integrated care. Next line down. Or next, keep on saying that. I feel so stupid. Sorry guys. Thanks Carlos. Okay. So this is a screenshot of their publication from the New England Journal of Medicine in 2010. And next shot or next slide. Team care was successful in improving outcomes for not only depression, but diabetes, blood pressure, and cholesterol. It had significant treatment effect sizes and also improved people's quality of life overall. And you can see all this stuff in some of these publications. The references are here. Next slide. With team care, one of the nice things was they used synergy to focus on a really at-risk population, which was a population with both diabetes and depression. They came to coin this term diapression, and if you recall my screenshot of Dr. Caton earlier, one of his quotes from a thing called quotehd.com was, depression is both a cause and effect of diabetes, and vice versa. Diabetes can both be a cause and effect of depression. The two form a nasty downward spiral, and they tried again to address both depression and diabetes in primary care. Until we really got them together in the teen care trial, they were not able to have a lot of synergy in making headway for at-risk populations with this syndrome of diapression. Next line, or next slide. Nowadays, based from 2012, we've got a Cochrane review that has gone and reviewed over 79, show some of these pop-ups here, great. 79 randomized controlled trials, including 90 relevant comparisons involving over 24,000 participants in randomized controlled trials, showing that collaborative care for depression and anxiety disorders is a very useful approach that saves money and improves health outcomes and improves satisfaction for integrated care and blending behavioral health services into primary care settings. Next slide. Not to riff too much off of collaborative care, but it's a very compelling new framework to consider integrated care and hanging your hat on integrated care, especially as we move toward value-based payment. And this is a screenshot from Sylvia Burwell, the director of HHS, talking about how our healthcare system is moving towards value-based payments. Next slide. Next slide. A lot of you kind of know about this macro stuff and MIPS and alternative payment models, etc. Collaborative care is growing quickly, and CMS just announced that it's going to be funding it out of primary care starting, I think, in 2018 via their physician fee schedule. They're just valuing the payment options for collaborative care and the delivery of collaborative care in primary care as we speak, even this summer. Next slide. So I told you I had two objectives. The second objective was this fancy horse and buggy thing. Next slide. So my point with talking about horses and buggies is that I think we are inclined to hold on to what we're used to in healthcare. And I think of this analogy a lot. It's as if we're on the West Coast trying to get to Hawaii. And we've gotten to the West Coast using horse and buggies. And we've got to fundamentally think differently about how we're going to get to Hawaii. Because we know the land is burning, and we've got to leave the United States as we know it and all get across the sea to this new land. And if we try to approach it with a horse and buggy system, it's going to be very frustrating. And we don't really use horse and buggies anymore. Everybody's comfortable with riding in cars nowadays, and everybody gets on an airplane. And there are risks, and when you first start out this stuff, it can be very challenging. But you know, nowadays we use horses and buggies for recreation, and it's fun. We have other modes of getting around that we trust in. When we reform how we work as physicians and how we think of ourselves as primary care physicians and psychiatrists, it can be very challenging to let go of the old and embrace the new. And so we've got to be able to think critically about what is best about our horse and buggy system and how do we take what we've learned from that and advance our notions of who we are as psychiatrists and primary care providers. So let's talk about that. Next slide. So when we think about what's needed for integrated care, or one aspect of integrated care, namely the collaborative care model, we can then dissect it by some of the essential workforce. So let's start off first with the behavioral health practitioner or the care manager. Is there any data or evidence out there from the learned experience from all these 79 RCTs and implementations, large-scale implementations of collaborative care? What does this care manager need to thrive and succeed in a collaborative care model? Next slide. Next slide. And then show some of the pop-ups. So fortunately, Petrusky and others in 2014 in the journal Psychiatric Services helped to kind of ferret out a little of this. If I was to distill the results of their analysis of the Diamond Project, which is a depression collaborative care program in Minnesota, they kind of said that to be a good care manager, you need to have dedicated time and dedicated staff with dedicated time to take on this caseload of patients of 40 to 90 people with depression in primary care. And then those care managers needed basic NICE skills. They needed to basically be able to collaborate with people, to talk to people. They needed to be warm and empathic. And they needed ways to engage another person in their healthcare, motivate them, and partner with them to engage them in their care. And so that's the basic, if I were to boil down the basic things that you need to be a good care manager, this is what you need. And a lot of different existing workforce elements are moving into this role. We've got licensed clinical social workers or social workers writ large moving into this role. We've got nurses moving into this role. We've got clinical psychologists at times moving into this role. We've even got in some places medical assistants moving into this role. And it's really amorphous and ill-defined, and that's why I leave it like this. We need basically dedicated staff with dedicated time and basic NICE skills to outreach and engage populations of care. They also need to be able to communicate well, follow up and be thorough, and document fairly well. And if you can do all those things, then I think you can be a basically good care manager. Next slide. The following set of slides is taken primarily from our team care trainings that we did with the University of Washington that we don't do as much anymore because of Dr. Caton's passing. These have kind of fallen off and been morphed into other things, but I use these because they're still useful. Next slide. And so if we look at the team care model for collaborative care, which utilized both a primary care physician consultant and a psychiatrist consultant, we can then think about how those roles might differ from traditional roles in psychiatric outpatient care and primary care. Next slide. So specifically, you might think to yourself, why would somebody need a psychiatrist, or why is it useful to have a psychiatrist in this caseload review process once a week? And there's a couple of points you should consider when you're thinking about designing your workforce. And then through those points, we can think about how the role of psychiatry might be changing or advancing. Next slide. So psychiatrists are particularly useful as consultants to these models because they have a medical background and they've been through some elements, they've been through some primary care training. They've been through 6 months of general medical care. They went through medical school, and they're familiar with what primary care and the provision of primary care is like in general. They also have this behavioral health background and can really speak to psychotherapeutic interventions, cognitive behavioral therapy, motivational interviewing, substance abuse treatment, and they have a long or a very wide background in general on general mental health and substance abuse care. Psychiatrists, sometimes in medicine, it's very hard to get others to change and others to adopt evidence-based recommendations unless it's seen as coming from a vetted source. When you're talking about psychopharmacotherapeutic interventions or medications to manage mood and substance use disorders or mental health disorders and substance use disorders, psychiatrists may have some more panache or more confidence, or the other primary care providers who would be responsible for enacting those recommendations may have some authority or legitimacy coming from a psychiatrist. It may be seen as having some more authority or legitimacy. Like I mentioned already, they have an experience with a spectrum of behavioral health treatments and can help to also identify when somebody is really not safe to be managed in a collaborative care environment and needs a referral to a higher level of care, what's known as stepped care in these collaborative care programs. So when somebody's not really making it and you've kind of exhausted most of your evidence-based treatment algorithm for depression, or now it seems like you have a more complicated personality disorder plus maybe a psychosis, plus mania or bipolar disorder presentation that really exceeds the capacity of a primary care system to manage, then that psychiatrist can help you with greasing the wheels into community behavioral health settings, or can even help to manage suicidal risk as it presents when you're managing depression in primary care. Next slide. So when we think through, when we think then to complete that prior thought, back to the previous slide for a second, Carlos, the psychiatrist's role can be changing in that they're not directly seeing patients. That's probably one of the biggest affronts to psychiatrists working in these models. Rarely do psychiatrists in current clinical practice actually work full-time in collaborative care. They're usually doing collaborative care a couple of half days a week, consulting to these teams and helping to bring an evidence-based perspective and a deep, rich evidence-based perspective to the primary care team in managing mood and substance use disorders in primary care. So that's probably the biggest change. The other change is the psychiatrist working without directly making assessments and kind of relying on the longitudinal aspect of managing populations in care and the care manager's longitudinal relationship and the PCP's longitudinal relationship to inform their diagnosis and their treatment plans and their evidence-based recommendations. This is something unusual for psychiatrists, but fortunately, younger psychiatrists are embracing collaborative care in droves, and many psychiatrists are seeking training through the APA. We'll show you some of those resources coming up. So if you've got a psychiatric or behavioral health workforce that's reluctant to engage in some of this stuff, there's lots of national opportunities to learn more about these skill set that they can acquire to be good collaborative care consultants. Next slide. So the primary care provider or the primary care physician, not the consultant, but the physician, has this role in these integrated care models to kind of oversee all aspects of the patient's care. They use the continuity that they've developed with their population over time to weigh the treatment recommendations against the patient's own clinical circumstances and maybe bring other things to light, like social or other aspects of their care that weren't immediately apparent to the collaborative care team. The primary care provider kind of helps to diagnose common mental health disorders and institute good screening programs. They have to do this anyway based off USPSTF recommendations for depression screening, for instance. The primary care provider starts and adjusts pharmacotherapy for these disorders with the aid and support from the psychiatrist consultant. They help introduce the patient to the team and the fact that they all work together. And they also have the consultants and the behavioral health practitioners on speed dial anytime they need to kind of get them on the horn and say, this is kind of a different thing than what I was expecting. Can you help walk me through this? And this curbside consultation aspect of these collaborative care models is really a big part of the secret sauce that helps them take off. Next slide. This slide talks about adherence and clinical inertia in regards to health outcomes in a Medicaid population. So this is from the Journal of the General Internal Medicine, looking at outcomes for diabetes. And it turns out that a lot of patients in Medicaid populations actually have fair to adequate adherence when they're on long-term anti-glycemic meds or hyperglycemic meds. The problem is not always adequate adherence or inadequate adherence to treatments. It's the lack of the treatment team to progressively intensify treatment in the face of somebody not achieving their clinical target. This is called clinical inertia, and it's equally accountable to people not achieving their clinical outcome goals, like a controlled blood pressure or a controlled A1C or a controlled PHQ-9, as anything else in medicine. So we fail to overcome this clinical inertia, and having a consultant primary care provider to the team can assist the existing primary care provider with just gently nudging them around, are we really advancing care in terms of making sure they're on the best antihypertensive treatment or statin treatment or going by the guidelines for blood sugars or depression. This is what the role of these consultants is to overcome this thing called clinical inertia. Keep on going, thanks. Keep on going, we're going to skip that one. So PCPs have this long-term relationship. The role of the PCP consultant is primarily to assist with the evidence-based management of these chronic conditions and give a new set of eyes to managing these populations and work with that care manager to engage people and make sure they're taking all their meds and help that existing PCP with managing the stuff you can never get to in primary care, namely statin therapy and insulin therapy and blood, all this stuff. It's kind of like you can have the collaborative care team working in the background to help give you the best tailored evidence-based recommendations around your patients. So it can greatly extend your ability to manage these chronic conditions in primary care, which includes depression. Next slide. Next slide. So I'm not going to go through that necessarily. Next slide. So these consultants, their main roles in this team environment, working as a team now, is to be supportive and clear on goals, not to lower self-esteem, be curious and problem-solve problems, and then to be available to the existing consultants when they have questions about the evidence-based recommendations and kind of where they're coming from or how they can modify the treatment plan. Next slide. Next slide. So next slide. Next slide. We're going to skip through a lot of this stuff. So this is a picture of David Bowie, God rest his soul. I think that when we're thinking about these changes that are required, they require us to think differently about how we can work together, how we can use data to help us identify populations that are at risk, and then use that data to give evidence-based recommendations and continually doggedly pursue engaging people and intensifying the treatment until those measurement-based targets are improved. Next slide. Here's a list of some resources real quick from the Ames Center at the University of Washington, which has some awesome resources on recruiting care managers. It even has job descriptions and other things. The National Council has a fantastic case to care management training that can be available. And then for primary care physicians, SAMHSA, the Integrated Care, the Center for Integrated Health Solutions, has some great trainings for primary care physicians that are coming into behavioral health settings. We haven't even talked about that notion of reverse integration. We've mainly been using this concept of collaborative care to help us think about how a psychiatrist's roles or a primary care physician's roles are changing in integrated care. And then with psychiatrists, we've got training to the SAM grant, which is a support and alignment network program to improve psychiatrists' understanding of collaborative care models. And then we've also got ways that we're training psychiatrists in basic primary care skills so that they at times can extend their scope of practice and manage general medical conditions when they're the only medical provider seeing patients. Next slide. This is from the SAMHSA Integrated Care website and the resources. You can download these resources and go to the Integrated Health Solutions, Center for Integrated Health Solutions website. I think the resources are on these slides. Next slide. And next slide. So that kind of brings us to the conclusion of this webinar. I know we've just got a couple of minutes. I'll turn it back over to Jeff or to the participants for any questions you guys have. Thank you so much.
Thank you, Dr. Vanderlip. Very informative. Really appreciate this. And while Carlos is kind of pulling together the questions, if we have any on the list, let me look. I know one question we had was around the difference between implementing rural and urban integration. So with everything you talked about, are there factors that must be taken into consideration with rural versus urban implementation?
So that's a fantastic question. And in Montana, I know you've got a lot of rural places. Here in Oklahoma, we've got a ton of rural places too. If you check out an article from Fortney et al., F-O-R-T-N-E-Y, and Pine, P-I-N-E, they've done some of the work on collaborative care in rural versus urban populations and whether or not you can have a centralized consultant repository, so like psychiatrist consultants, can they be urban in an urban environment and consult out to rural places and clinics? And the answer is yes. You can have kind of a hub and spoke model for collaborative care where you have centralized consultants and then care managers and others who work on the ground in those rural practices. Sometimes, depending on geography and travel time, those care managers can travel to different primary care sites and cover a couple of primary care sites if you can't get your enrollment your enrollment numbers up for a caseload the size that is probably necessary for those care managers, like I mentioned, somewhere between, I'm going to say, even down to 30 to 60 patients with depression in primary care settings, for instance.
Okay, thank you. Another question was the difference between primary care for adults and primary care for kids, the pediatric aspects. Is there any differences with that approach if we're working with kids?
Most of what we're talking about with collaborative care is based off of the chronic care model. And with kids, the bulk of chronic conditions are mainly behavioral. You don't have a lot, I mean, you have some diabetes, you have some obesity, asthma is a big one, and then preventive care. But preventive care is like a checkbox kind of thing. Did you get your immunizations? Did you get your X, Y, and Z? And you can kind of check that off and be done with it from periodically. So it's hard to think about adapting the collaborative care model into pediatric populations, but they've done it. They've done it down to the ages of 12 and 13 for adolescent depression and published on that. But even before that, if you take some of the principles around collaborative care, that team-based concept, measurement-based treat to target is one of the most challenging ones, but it can be applied to a pediatric population in behavioral health settings. And what you can get then is you can take Vanderbilt scores for ADHD, for instance. This is a very medical model focus, but nevertheless, it can be very useful to think about. You take Vanderbilt scores and you measure and track those as your measurement-based treat to target. And Vanderbilt is a free online, you can download it. It's a scoring system for measuring kids' ADHD symptoms. And it's focused primarily on ADHD. The science of this stuff will evolve as our measurement-based outcomes evolve. And we're all moving towards this notion of evidence-based or measurement-based care as a critical component of behavioral health services. And we do better and we have more efficient services when we're able to measure our care and intensify our treatment on that. There's a lot of other child psychiatry models out there. The McPAP model, which is the Massachusetts Pediatric Access Program, is kind of a data bank or a call bank for child psychiatrists who are on call for curbside consultations and a system to support them with doing that with pediatrics, and that is a popular model these days. A lot of systems are going with the ECHO model to assist with a centralized repository of consultants. Those models often lack necessarily a population focus where they can track the population being treated and make sure that nobody slips between the cracks. They often also lack a measurement-based care focus, but that's not bad, and sometimes you have to start wherever you can start. And in the state of Washington, nearly next door, separated just by Idaho, you have some other advances in child and adolescent access to care via telemedicine and other things. So there's a lot of different models out there, and like I said, the collaborative care model is just one model under the larger umbrella term of integrated care. But I would encourage your systems to think critically about measuring your outcomes, measuring your clinical outcomes, and having a way to track your populations to make sure that nobody's slipping between the cracks, because that's some of the real secret sauce of this collaborative care model.
Thank you so much. Well, I think we're at our time. I really, again, appreciate all the questions. If we have a few that are left over, we'll respond to those via email with everyone. This will be recorded and archived. We'll send out the link to folks in Montana. Again, thank you very much, and hope everyone has a great day.
Thank you all. And please, I just wanted to do a quick reminder of the dates that we have listed there. For our July 8th group call, we are working to reschedule that, and we're still in progress. I'm working with Joan. September 1st, we have another group call at 1 p.m. Mountain Time, 3 p.m. Eastern Time. And September 16th, we have another webinar at 1:30 Mountain Time, 3:30 Eastern Time. I hope you all have a great day.
Thank you all.
Thanks, everybody.